Therapy-related MDS are defined as MDS onsetting in patients who received a previous treatment for a primary tumor or an autoimmune disease. They are usually late complication of cancer treatment, and most frequent cancers are lymphoproliferative diseases, and among solid tumor is breast cancer. And the treatment plays a very important role, causative role, and they were traditionally classified as t-MDS following alkylating agents. And these were also associated with a longer latency. In AML, we can have t-AML following topo-2 inhibitors treatment. And the type of treatment not only plays a role in the onset of the disease, but also shapes the type of mutations or the accumulation of mutation in the clonal evolution of the disease. One very important factor which has been described in the last years, 5 to 6 years, is the role of CHIP, so of acquired CHIP in the bone marrow of patients at the time, which is identifiable at the time of initial tumor diagnosis prior to any treatment. And the CHIP is present in prior to any treatment in about 30 to 50% of the patients who later develop a t-MDS. And so this lays the fertile background for then the onset of additional damage due to the chemotherapy. And this then leads to the development of MDS. These MDS, therapy-related MDS, are characterized by an unfavorable biologic profile. They are more frequently high-risk MDS with several cytogenetic abnormalities and complex karyotypes. And this, of course, is associated to unfavorable prognosis in these patients. And also, they are characterized by a number of somatic mutations, which is not significantly different from de novo MDS, but it's the type of mutations which is different, with frequent involvement, for example, of the TP53 genes, which is mutated in a high proportion of patients, 30 to 40% of cases, and other genes such as PPM1D.